vitamins, of course, that we already went over, and then we talk about lifestyle. One of the biggest things for bone and building bone is weight bearing.
It does this.
It does this?
Yeah.
It wasn't operator.
No.
I can keep talking. So one of the biggest things is walking. Weight bearing is important for bone, just like not weight bearing or being in a wheelchair is bad for bone. Walking is good for bone. It doesn't have to be fast, it doesn't have to be fancy. It simply has to be one foot in front of the other at a relatively continuous motion, maybe more than 5 minutes or so, to stimulate or wake that bone up. The osteocytes, which I mentioned earlier, they are the terminally differentiated osteoblasts. Those osteocytes are mechanosensors. So every time you take a step down, you wake them up, you stimulate them. It's why lately, maybe in the last 5 years or so, vibrating platforms have kind of become a trendy thing for fitness and bone, because we're basically shaking the bone and we are giving those osteocytes mechanosensation to then wake up and look at the bone around them and go, ooh, I've got some bad bone right here. I need to bring in the osteoblastic system. And so very, very important to walk. It doesn't, like I said, running works, elliptical works, bike does not, because you're not weight bearing. The pool does not, because you're not weight bearing. Anything, though, on your feet works. Zumba, line dancing, walking through Walmart. It doesn't have to be fancy. Balance and strength training also important. Now, it doesn't build bone, but it does keep you off the ground. And so if you don't fall, you're a whole lot less likely to break. You can break, you can plant, twist, and break your femur and then fall. Happens all the time, but you're a whole lot less likely to break if you don't hit the ground. So strength training keeps you off the ground. So we work really hard at trying to get our population 50 and over to work on strength and balance. Obviously, stop smoking, stop drinking. Although by the time some of my 75, 80-year-olds, it's tough to get them to change anything. So I try, but it doesn't help. And then I do a don't be stupid speech. Don't climb. If you have osteoporosis, don't climb on a 10-foot ladder. Don't clean your gutters out. Don't be on the roof. If you fall off the roof, that is not going to end well. It's not going to end well if you trip over the dog, let alone fall off the roof. High heels in women, women love their high heels even at 85. Terrible idea. So are flip-flops. Flip-flops are actually one of the more common causes of fracture we see in adults at OSOI in the months of June, July, and August. The front of that flip-flop catches on a threshold, catches on something, it folds underneath. All the girls in here, we've all had these, right? You catch it like, whoa, I got this belt, right? Flip-flops are awful. They're bad for our kids, and they're really, really bad for us. Now, if you don't have osteoporosis, you're just going to hurt your pride if you fall. But if you have osteoporosis, you're going to break your arm. That's the outstretched arm fall. We call that forearm fracture in July the flip-flop fracture. We also want to make sure that we're evaluating falls risk in patients, which can be hard to do, but you can, in an office-based setting, but you can send out home health to do this, and they'll look at the home situation, but always important to try to mitigate as many risk factors as we possibly can. Make sure someone's checking in on them. Being a dark environment is a high fall risk, so a lot of femur fractures happen at night, so making sure that they have night lights or a flashlight or something. When we talk about physical activity, if they already have osteoporosis, we have to be a little bit careful. There's some things we don't want them to do, especially end range motion things. So spinal compression fracture is a huge risk for those osteoporotic patients, and it doesn't take much. You can cough, you can laugh, you can sneeze, and you can have it. So if you have osteoporosis of the spine, I really don't want you to pick up the 50-pound bag of dog food. Bending and lifting is a really bad idea. Any yoga or Pilates that takes you to a extreme range, whether it's a twist, a forward or backward bend, we don't want it. Within a mid-range is fine, but any extreme range or heavy lifting is a terrible idea. And we generally want them to have it 1 foot on the ground at all times. There's a lot of exercises that are jumping, the plyometrics and things like that. Again, 2 feet on the ground. Posture is important as well, trying to mitigate as much of the kyphosis as we possibly can. Again, these are just all of the unsafe movements that can result in fractures, specifically of the spine. I've had some of my really fit women who just, it kills them if they have osteoporosis, because they are probably stronger than I am, very, very fit women, and they were doing a crunch and they had a compression fracture of the spine. Having strong muscle does not mean you have strong bone. Balance exercise is really important. Our balance decreases as we age, and so we want to make sure we really exercise your balance organ is what that is. Assistive devices, it's a pride thing. You don't want to walk with one as you get older, but it's really, really important so that you don't fall. We can also use balance devices that fit in shoes. These are more balance braces. They help with ankle stability and in foot drop as well. So I have several patients that use these. Hip pads, those look cool, don't they? They also even, the pads that football players wear, I have a couple of older ladies that will wear those. It helps a little bit with shock absorption if you are going to hit the ground. All right, medications. So we have a whole groups of medications for osteoporosis. We have ones that have been around forever and a day, and we have some that were approved about 6 weeks ago. So we have a whole slew of them. All of those medications work in this bone remodeling system somewhere. They mitigate something in that system. So it's not a very complicated issue. They either have to do something to the osteoclast, or they have to do something to the osteoblasts, or a little bit of both. But keep in mind, this system is cyclical. So if you stop one part, you're stopping another, right? So keep that in mind as we talk about medicine. So hormone replacement medicine, so this is your estrogen, maybe it's testosterone, and then maybe it's Evista, which is just making your natural estrogen work better. Though that slows the turnover process. It doesn't stop anything, but it slows the osteoclastic activity, which is a good thing. The problem with using hormones with bone is that they have all these other side effects. We're increasing the risk for stroke, we're increasing cardiovascular risk, maybe breast cancer risk. So using hormones for specifically bone has really fallen out of favor a little bit. Generally not a first line. Occasionally for me they are. If I have a young female, maybe she's 40, 45, 0 other risk factors, we have a few years, I can buy some time, we might use hormones for her, but it's a rare group. This is not a big group that we use specifically for bone. Now if they are considering hormone use, they're just not sure if they want to, they're going through a perimenopausal time, and they're not sure if they want to. If they have some bone loss, we put that in the pro column, and they might decide, I want to use hormones for a few years. But just specifically for bone, we don't use them just a ton. Contraindications, I talked about these before. Of course, the breast cancer and MI risks are pretty huge, and so patients, especially if they smoke, that's not a good option because we are already have an increased risk for MI there. The anti-resorptive medications, specifically bisphosphonates. Bisphosphonates are ones you guys might have heard of. They've been around forever. Maybe your grandma or mom were on them. Fosamax, Beniva, Actonil, Reclast. Those medications inhibit bone resorption. So they stop those osteoclasts from doing what they need to do. And they were the first bone medications that we ever had. So the idea was, well, if we just stop the bone resorption, money, we're good, right? We're not going to take any bone up. So then we'll have all this bone and life will be good. The problem after a while we discovered was the bone that was left behind was never being repaired or remodeled. So we had some downsides to them. We were leaving, after a long period of time, we were leaving behind older and fatigued bone, which there was a lot of density there, but the quality was not so good. Now remember what we care about. We care about the strength of the bone, and it's an equation. So if we just have the density, but we don't have the quality, we're still going to break. The side effects of bisphosphonates have also been an issue over the years. A lot of these pills are very difficult to take. They require patients to take them and sit up for 30 minutes after taking them. Patients with any kind of active upper GI issue, so an active GERD, Barrett's esophagus, anything like that, we want to make sure we don't ever give them an oral bisphosphonate because we will make that GI problem significantly worse. Bleeding ulcers and things like that. So we want to really avoid that. If their GI problem is under control, sometimes they can tolerate them. These medications are primarily weekly or monthly. We also have IV and infusion forms of these medications. Beniva can be given by IV every 3 months, and Reclast can be given by infusion once a year. Reclast had a very popular time, maybe 8-10 years ago. Because it was once a year. Problem is, it's one of the strongest anti-resorptives we have. So it really suppresses. Does a great job. It really suppresses anti-resorptive activity. The problem is By doing so, it also suppresses the osteoblastic system. And if you're an orthopedic surgeon, do you want that bone really suppressed? If you're going in there and doing an elective bone surgery to put a total hip implant in, and this patient had reclass 6 months ago, the risk of delayed healing is huge. And so we have to be very careful with these medications if the patient is around any type of orthopedic surgery. Side effects, we've already talked about a lot of these. There is a flu-like symptoms, or side effects that this group or this class can have. It acts just like the flu. You can have fever, very, very bad bone aches, and headache. That is a side effect that if they have that for several days, we won't give them another dose because it generally gets worse over time. Osteonecrosis of the jaw is also a major side effect from this group of medicines. It is loss of the mandible. And the mandible is a pretty important bone if you want to eat. And so we lose our teeth, we can't have implants put in, and part of the reason is because they're great suppressors of those osteoclasts. And the mandible really needs that system to work. Now, osteonecrosis of the jaw is a relatively rare side effect, but it does happen. I see patients who have had osteonecrosis for 10 years from a previous use of Fosamax or Actonel or even Beniva. So it is a risk, and it's something that patients should know about before they take the medicines. Dentists this is a big deal in the dental community. If they are taking any of these medicines, they cannot have any dental work like extractions or root canal. They can have filling done, but they can't have anything that messes or potentially messes with the mandible bone. In 2008, the FDA put out a big kind of warning on the bisphosphonate class. They'd been out for almost 10 years at this point, and we were discovering that patients who had been on these medicines for a really long time or consistently without a break were breaking their femur bone. And not a normal femur fracture, but a subtrochanteric fracture of the femur, which is kind of a weird fracture. Most older patients will fracture at the femur neck, but these patients were fracturing subtrochanterically. And so the warning was, if your patient is on, say, weekly Fosamax, and they come in and they complain of thigh pain or groin and thigh pain, that is a huge red flag, and you need to immediately remove the medication, number one, and have them screened to make sure they are not showing stress fractures of that femur bone and are getting ready to have a femur fracture. Because if we can know ahead of time, they can go in there and reinforce it before it breaks, which is actually an easier surgery than waiting for it to fracture. This is a big issue with orthopedic surgeons. They see a lot of subtroch fractures, and they like to blame all bone medications for them. And so as a result, orthopedic surgeons do not love this class of medicines for a couple of reasons. This one primarily, and two, because they suppress the bone activity. And they want bone activity. Surgeons don't want quiet bone, they want really active, happy bone. And so these medications we use primarily just for 5 years or less. What we discovered is if we don't use them forever, then we decrease that side effect profile, or the risk of osteonecrosis and the risk of subtrochanteric fracture. So we use them for 5 years or less. At 3 years, the risk goes up a little bit. At 5 years, the risk goes up a lot. And so at 5 years, we take a holiday, a break, a medication holiday. How long we have to take a holiday for, we don't really know the answer to that question. Some people say a couple of years, some people say 5 years. There's not, it's kind of reevaluate the situation and see what you think. Use your clinical judgment. These are the instructions for using them. Remember I said you have to sit up and to drink a whole lot of water. It's because they can be a little bit noxious to the GI tract, and so we want to make sure they get down and stay down. So we don't want to take that pill and go back to bed. Calcitonin is an oldie but a goodie. It's been around a long time. It's a nasal spray, and it was indicated primarily for use after spinal compression fracture, which is not a ton that we do for spinal compression fracture, kyphoplasty, for some patients, and they're very painful. It's a very painful fracture. And so we will use calcitonin sometimes. It's not used widely anymore because it doesn't really help long-term for bone. Short-term, it maybe helps pain a little bit for those spinal compression fracture patients, but it's not used long-term. A lot of side effects to it, especially in the nose, just basically epistaxis. Parathyroid treatment. So parathyroid hormone is an anabolic medicine, meaning it stimulates the osteoblastic system. There is some stimulation of the osteoclasts as well, because you can't stimulate osteoblasts without stimulating osteoclasts. So they're both stimulated, but osteoblasts are stimulated at a much greater rate than the osteoclastic system. So these medications are known as anabolics, much like anabolic steroids build muscle, anabolic bone building medicines build bone. These medicines are the parathyroid hormone of that peptide chain 1 through 34. The parathyroid hormone has 84 peptides in it. This is 1 through 34. 1 through 34 is where bone is concentrated for the parathyroid hormone. Its job for bone is in those first 34. And so there are two anabolic therapies. Last year when I did this talk, there was one. Forteo has been around for about 15 years, 14, 15 years. Tymlos has been around for about 4 weeks. It is the same thing. They're the same medicine. There's not a lot of ways you can build bone without cheating and doing what the body does naturally. So these hormones basically mimic what the body does. They build bone. Tymlos took a molecule that has been around a long time, is really good, doesn't have a lot of problems or a lot of side effects, and decided to make it bigger, faster, and stronger. So it is in 4 times the dose of what Forteo has been. Whether that turns out to be a good thing, I guess we'll wait and see a little bit. The indications for these bone building medicines are patients who are a little bit greater risk, or we'll use the bisphosphonates in patients who are osteopenic, maybe just try to slow down the loss of bone. Patients who have already fractured, they're really high risk for fracture, they're getting ready to have an orthopedic surgery, maybe spine hardware to put in. If they have a lot of bone loss, they're osteoporotic, we need to build it back. We don't want to suppress that bone, we want to fire it up. And so we will use medications like these to fire that bone back up. Specifically, these ones are indicated for high-risk patients. In the past, they've been indicated for what I like to call the train wreck patients. We used to hold these medicines back. Forteo's been out for 15 years. And when you start talking about bone medicines and we get to this lecture, we go, well, why wouldn't we always use a bone building medicine? That seems like a much better plan. It is a much better plan. Unfortunately, Forteo, the cash price of Forteo is about $2,800 a month. The cash price of Tymlos is about $1,800 a month. And they're very expensive medicines, very well covered by insurance now, but historically they have not been. So we saved them for the train wreck. We waited until you had 2 hip fractures, a pelvis fracture, maybe a spine fracture, and then we'd say, well, we do have this medicine that builds bone back. Maybe we should use it. And so now Medicare and insurance companies are saying, whoa, this is an expensive disease we've got going on. Turns out 2 years, we use these medicines for 2 years. 2 years of therapy is cheaper than a hip fracture. So let's actually fix the bone before it breaks rather than wait until you break and then fix it. And so these medications have become far more popular. Men and women over the age of 50 that are high risk for fracture, younger men and women who are at risk for fracture, have a history of fracture, have osteoporosis. Tymlos is currently only indicated for women, but I expect that they will be indicated for men here soon. Anybody with multiple fracture history should be treated at first with an anabolic therapy. These medicines are generally very well tolerated because it's a hormone you already have, so we're not giving you something you don't already have. The biggest side effect that patients will generally see are growing pains because you're going to grow, not taller but more bone. The patients we don't want to give anabolic therapy to are your Paget's disease patients, anybody with bone metastases or a bone cancer, metabolic bone disease, somebody that has a history of hypercalcemia because they may have hyperparathyroidism. So we don't want to do that. So let's start. So these medicines are parathyroid hormone, right? But hyperparathyroidism causes osteoporosis. So that's weird, right? The problem here is, or the difference, is that this medication is a burst therapy. So you get a tiny amount of parathyroid, and then it gets the heck out of Dodge. It's in there, it does what it needs to do, and gets out. It has a half-life of around 4 to 5 hours. Endogenous parathyroid hormone is high all the time. So you have high parathyroid in your system the entire time, 24/7. Too much of a good thing is not a good thing, right? Same thing with parathyroid hormone. If you have endogenous production of parathyroid hormone all the time, 24/7, you're going to lose bone. It's just too much of a good thing. When we give you Tymlos or Forteo, abaloparatide or teriparatide, you're getting a little burst of hormone. It doesn't stick around long, it gets in enough to say, oh, make more bone. Stimulate it, make more, do what you need to do, and then it stops. And that actually produces more bone. That is the difference. let's see, side effects. The biggest one here is a transient hypercalcemia, which is why we don't want you to have, A, we don't want you to be taking too much calcium to begin with, and B, we want to make sure you don't have hypercalcemia prior to starting the therapy. Let's see, did I put it on here? Yes, I did. One of the biggest issues with these medications is they come with a boxed warning for osteosarcoma. Osteosarcoma is a bone tumor, bone cancer, primarily in children, but it's rare in adults, but it happens. Osteosarcoma was seen in the rat studies for both of the drugs at doses that were 15 to 100 times the human dose. They've never been seen in humans, they've never been seen in chimpanzee, monkey studies, or sheep studies. Tim Lowe did bone studies in sheep. So they've always been confined to rat studies, but the FDA did issue a black box warning. It was initially a black box warning when Forteo came out, downgraded to a box warning, which is somehow different. It's still a black box, I don't really know what the difference is, but downgraded to a box warning after about 8 years. It's never been seen in the Forteo population, and Forteo's been out a really long time. There was a registry for Forteo for the first 8 years it was on the market to make sure it never occurred, and it didn't. So it's not something we worry about, but when patients look at literature or they Google, it will come up. So it's important that you know what that box warning was for. Denosumab or Prolia. Prolia is a very, very commonly used bone medication right now among primary care, rheumatology, not so much, a little bit in orthopedics, not a ton. So denosumab or Prolia, as its branded name is, I think it's been around since 2005 or maybe 2008. It is an anti-resorptive like those others, but it's not a bisphosphonate. So it works in that osteoclastic system to suppress the osteoclasts, but it does it in a completely different way. And so it uses what we call this rank ligand system, and it inhibits rank L, so it allows those it actually suppresses the osteoclasts in a completely different way. It was designed to maybe allow the osteoblasts to still do what they needed to do. We were hoping it was going to be the best of both worlds. Suppress one, stimulate the other, everything's great. Problem is that it didn't really work, and in true human studies, you really still have a lot of osteoclastic suppression and very, very little osteoblastic growth. So same kind of rules apply with this one. We have to be careful around orthopedic surgery. We have to be careful around anybody who's had a fracture. We don't want to delay healing. You wouldn't want to give this if somebody had a fracture 6 weeks ago. You don't want to suppress the bone. So we have to be very careful not to give them any type of anti-resorptive therapy. Side effects of denosumab, the biggest one is bone pain. A lot of patients will have either hypercalcemia or bone pain associated with it. It also has the risk of the osteonecrosis of the jaw and the subtrochanteric hip fracture. It also had some there was a brief period where they thought there were some other fractures occurring with denosumab patients. In the Big Freedom trial, they didn't see it, so that's an iffy side effect right now. Orthopedic surgeons have been very aware of Prolia for quite some time because it's a 6-month drug. So we give it and it wanes over the course of 6 months. So if you have a patient that had a Prolia injection in January, you really don't want to put a total hip in them in February because it's at the peak of its bone suppression. So we have to be a little bit careful with this type of medication. And if they fracture during this time, it also can delay healing just a little bit. So it might be a reason to give them a bone stimulator earlier, things like that. Anything to fire up that bone. Also, recently, and that's not on there, denosumab had a change in the label to warn about stopping it abruptly. That medication is also one of those 3 to 5 year window medicines, but if you stop it abruptly without changing to something else or doing something different, maybe changing to a bisphosphonate or changing to Forteo or Tymlos, patient will have rapid and severe bone loss below baseline. And so it got its own box warning in January of this year to say you need an exit strategy, don't just stop it. Which providers are pretty good about that, but patients, they love to stop their medicine. And Prolia is only every 6 months. So, goodness, I'm busy, you're busy. Do we remember to do everything? Heck no. Something that's every 6 months is very difficult to remember. So sometimes patients forget it accidentally. They just never went back and got their six-month follow-up. Well, turns out there's been a lot of fractures in months 7 to 9 after Prolia has waned and fallen off if they are not treated with something else. So also an issue, we don't want them to stop therapy. Pharmacies have really ramped up their education of patients on that as well. You can combine therapy. We can have 2 anti-resorptive medications at a time, which is a lot of suppression. There is some the BMD gain there, bone mineral density gain, in doing that. Or you can have an anti-resorptive and an anabolic medication. When you go to the research and you look at what is the best thing that we could do for bone to prevent fracture, what do the numbers say? The best combination of therapy is to start with an anabolic medication, use it for about 6 months, keep using it, and throw on at that point some type of anti-resorptive medication. So build the bone and then save it. It's a great option. The problem is 0 insurance companies will pay for that. Once you have patients on some kind of therapy, we want to monitor them. And so we want it every year to 2 years, we want to monitor these patients. If they're on anabolic therapy, for sure every year. If they are on other therapy, 2 years. I see a lot of patients that have been on one of the bisphosphonates and nobody's done a bone density scan on them for 5 to 10 years. And so it's very important to, once they're on a medication, don't just hit the refill button and keep refilling it. Think about whether or not we need to reevaluate the refill. How long have they been on it? Have they been on it for 5 years? Have they had a bone density scan during that time? Is the bone density scan changing at all? Is it getting worse on this therapy? What do we need to do? How long do we treat? We talked about this with the bisphosphonates already. For sure, the bottom line here is no more than 5 years. The anti-sclerostin antibodies, I'm going to go back again. The anabolics are 2 years. We treat with them for 2 years. The anti-resorptives we treat for 5. We don't do anything to bone forever. Bone shouldn't be suppressed or stimulated forever. So what's coming, we also have anti-sclerostin antibodies coming. Potentially maybe next year we'll have an anti-sclerostin antibody. These were found by accident. There's a group of people in the world that have really awesome bone. And they just happen to have a genetic change that encodes for this gene that makes them, there's an inhibitor that they have that helps them to have really good bone. And so they created one, and an antibody to this gene, and potentially it will allow us to have both anti-resorptive and anabolic therapy in the same drug. Repeating DEXA scan, 1 year if they're on therapy, 2 years if they've been stable on medication, it's a stable patient, 2 years. Longer if their DEXA scan has been over multiple years has been normal. Then you can start going to longer periods of time. Fractures, these are the more common osteoporotic fractures that you will see. The compression fracture there on the left side, which is one of the reasons we have kyphosis in our older patients. They have these wedge compression fractures. It's not really a wedge one, but they have a wedge compression fracture, and you put one wedge on top of another, and pretty soon they end up like this. It's a big C. So compression fractures are really important to diagnose and really important to follow up on for bone. The compression fractures, very rarely are they found in the acute stage. We actually find them accidentally. So if you do a CT scan on somebody's abdomen and pelvis, and the radiologist notes on the bone part of it that they had a compression fracture or a possible compression fracture at L1, even though they were there for acute abdominal pain and you were looking at another appendix or whatever else you were looking at, and that's fine, you need to pay attention to that compression fracture, because one compression fracture makes you 2.5 times likely to more likely to break your hip, 5 times more likely to have another compression fracture, and pretty soon you're going to have compression fractures all up and down the spine. So 1 leads to 2, leads to 5, and then all of a sudden you're breaking everywhere. So compression fractures are a crystal ball, and we find them accidentally. It's not something, most patients will lift the dog food bag, they will strain their back, they'll take some Advil, they'll go to bed for a couple days, they'll feel better, they'll take a hot bath, go to put ice on it, do something, and in a couple weeks they feel better. And a lot of them won't ever go to the doctor's office, and so you'll never see them. And we never know they have these until you do some other imaging. But very, very important to know. The distal radius fracture is that is very much a crystal ball fracture. Almost every, I would say about 95 to 98% of the hip fracture patients that I see have had a distal radius fracture in the previous 7 to 10 years. Sometimes they don't even remember they had it though. I'll ask them, have you ever had any broken bones or fractures? And they say, no, I don't think so, not really, no. And I'll look at the wrist and they'll have a scar right here from an ORIF surgery. And I'll ask them about the scar. Oh, that was just, yeah, I mean, I just cracked it though. I just cracked it, it was no big thing. They put a screw in and I'm fine. Cool, that's a broken bone. And that fracture right there made you 5 times more likely to have this fracture. So orthopedic surgeons have been charged nationally with preventing hip fractures. And by doing so, they do that by identifying hallmark fractures that lead to hip fractures. And that is the spine fracture there and the forearm fracture. I would also add to some degree humerus fractures, but that's not exactly on the list. It's mainly compression fractures and forearm fractures. Those have to be identified, they have to be looked at, and they have to be screened for osteoporosis every time. The Academy of Orthopedic Surgery has a program called Own the Bone. And Own the Bone was developed about 10 years ago to encourage orthopedic surgeons and get them to pay attention to bone beyond putting hardware in it and sending patients out the door. They wanted them to pay attention to it for these reasons right here, to try to prevent fracture. And so basically getting surgeons to own the problem. So that we don't have that hip fracture there on the right. That's a subtrochanteric hip fracture. And so that's a typical bisphosphonate fracture right there. The femur neck fracture would be the one where grandma just turns in the kitchen, kind of plants and twists, snaps at the femur neck and then falls. That is very commonly at the femur neck. If you need me for any reason, I'm happy to have you email me for anything. Always happy to answer questions or just whatever. I've been in practice too long. So, like I said, I was in primary care for about 11 years. Diapers to diapers primary care. We did everything. And now I do one thing. So it's a huge change. So if anybody has questions on this or clinical practice or anything, happy to answer questions. And we're a little early, so you get a little break. I talked really fast.